The central facial paralysis, it is an upper motor neuron lesion, or it's a paralysis of the one half of face caused due to any lesion in the upper motor neuron pathway. So since we have discussed the anatomical part in the last video, you will be remembering that that's from the cerebral cortex, the descending tracts which run to the pons, that is the cortico-bulbar tract. It crosses to the opposite sides and reaches the pons of the opposite side. That's the facial nucleus. Facial nerve nucleus is situated, where the facial nerve nucleus is situated. So any lesion in that pathway, it can lead to a central facial paralysis. And the facial nucleus or the facial motor nucleus in the pons, it is usually having two divisions, that is the dorsal and ventral divisions. Usually from this nucleus, the lower motor neurons supplying the muscles of the upper and lower face arise. Totally the facial nerve which supplies the upper and lower face, facial nerve and its branches arises. You can see that the dorsal division, it receives a bilateral upper motor neuron input, that means from both sides of the brain. That's the dorsal division of the nucleus. It receives input from the bilateral upper motor neuron, that is from both sides of the brain, while the ventral division, it receives only from the contralateral input or the opposite side of the brain. So as a result of this, we can see that the upper face, it is crossed and uncrossed connections. So the upper face is supplied by crossed connections from the opposite side and uncrossed connection, that is from the same side. Whereas the lower face, our lower face, it is having the inputs from crossed connections only, that means from the opposite side only. That means we are in our upper face is having a support from the uncrossed connection from the brain, whereas in lower face they have only the crossed connections from the opposite side. So due to this support, usually what happens is that in the facial paralysis, you can see one side of the whole half of the face is paralyzed. So here in central facial paralysis, what happens is that since we are having an uncrossed connection from the same side of the brain or the supranuclear area, the frontalis muscle and the upper orbicularis oculi, it tend to be spared. It is getting inputs from the ipsilateral or the same side of the brain because of the uncrossed contribution from the ipsilateral supranuclear areas. And that is why we can see that in central facial paralysis, the patient is able to move his eyebrows. Okay, so whereas the lower face, which is having crossed connections only, that is being affected, and all the weakness and paralysis is seen below that. So in this diagram, it's clearly shown that from the cerebral cortex, take the first diagram, it's the upper motor neuron lesion. So from the cerebral cortex, the line or the pathway, cortico-bulbar tract, it runs, you can see two pathways, that is one is coming from the same side and other from the opposite side. Okay, that reaches the pons or the facial motor nucleus divisions. This is ventral and dorsal divisions. So dorsal divisions, you can see that both the bilateral supply is being present in the dorsal divisions, whereas the ventral division, it is having only the crossed supply from the cortex. And you can see that from these nucleus itself, the lower motor neurons are emerging, which are shown in green, to the upper face and the lower face. You can see that the nerve the part which goes to the upper face, that is having a supply, that is having a support from the ipsilateral, the same side of the brain. and the part which supplies the lower half of the face, it is having connection only with the crossed or the from the opposite side of the face. So as a result of it, when the paralysis occurs, what happens is that the patient is able to move his eyebrow, since the lower motor neuron is having a central support from the same side of the brain. I think it is clear. The green, you can see a lesion. A lesion is shown in the cerebral cortex, and when that lesion occurs, you can see the whole supply to the pons or the facial motor nucleus is cut off there, and the lower motor neurons will not be able to move the muscles of facial expressions. But you can see one connection to the um, dorsal nucleus, that is from the same side of the brain, is there. So that gives a supplies to the upper face, that is the eyebrows, the muscles of frontalis and the upper part of the orbicularis oculi, and that is having a central connection from the ipsilateral side. So that part will be moving in the upper motor neuron lesion palsy, facial palsy. And the second diagram is a lower motor neuron palsy, that is a Bell's palsy usually. And here the lesion is somewhere down, that is below. Once the once the facial nerve it leaves the facial nucleus, the lesion can occur anywhere in the pathway. So that is the lower motor neuron lesion. And here what happens is that both the upper the supplying both the parts supplying the upper part of the face and the lower part of the face is directly affected, since the last part of the nerve is cut. So that is the reason why in Bell's palsy you can see the whole half of the face, including the eyebrows, will be affected. For summing up, so I have given the two lesions in a single picture. You can see that in the case of a lower motor neuron lesion, the lesion is below the nucleus, that means somewhere in the pathway of facial nerve, final pathway of facial nerve. So the whole supply input to the muscles which it supplies is cut off. So the patient is unable to raise his eyebrow or smile on the affected side, and there is a paralysis of ipsilateral upper and lower facial musculature. Okay, and in the upper motor neuron lesion, you can see that there is a paralysis, but the patient is able to raise his eyebrows. That means that eyebrow is having a connection from the same side of the brain. You can see that from the same side of the brain, and that connection gives the ability to supply the input to the frontalis muscle, which helps to raise his eyebrows. But you can see the lesion in the cortex in green. I have marked it in green. That lesion it prevents the whole input from the cerebral cortex, and from that means in the opposite side, coming from the opposite side, and it mainly affects the lower half of the face, and the patient is unable to smile. Now we'll continue with the details of the Bell's palsy. Bell's palsy, as I've already mentioned, it's a lower motor neuron lesion. That is, the lesion is occurring anywhere after the nerve emerges from its nucleus in the pons. One of the most common neurological disorders affecting the cranial nerves. It is an abrupt onset, sudden onset. It can be, mostly it is unilateral, and it can be bilateral also. Then there is a peripheral facial paralysis of one half of the face without a detectable cause. First described more than a century ago by Sir Charles Bell, is the person who found it out. Yet it has so many controversies along the with regards to its etiology and management. The Bell's palsy is certainly the most common cause of facial paralysis worldwide. So when I say it's the most common cause of facial paralysis, it is almost 50% of the cases it's Bell's palsy of facial paralysis, which is Bell's palsy. And the most common age of incidence set is 25 to 30 years. And male to female ratio it is 1:1, and the left side is to right side, it's again equal 1:1 chances. Unilateral cases are more than bilateral cases, and the increased risk is seen usually pregnancy and diabetes mellitus, and the recurrence rate is usually 10%. So when we come to the etiology, there are many hypotheses on how this disease has occurred. So a few of them are earlier and old hypotheses which are not even used now, but I'm just mentioned this. I'll just read through this just to know. It's for your information. That is rheumatic hypothesis. It's in 1936. Rheumatic swellings. It is caused due to rheumatic swellings which may press the nerve. That hypothesis is not used now. It's obsolete. And then cold hypothesis. Again, Charles Bell told that there is exposure to extreme cold or cold rod. It can produce constriction in the nerve, leading to Bell's palsy. Another is ischemic hypothesis. Ischemia means there is lack of blood supply or decrease of blood supply. The factors like cold again, then carbon dioxide excess, vasomotor instability, blood vessel disorders, then injury, toxic reasons, allergic reasons, and certain hormones are also included in that hypothesis. Another one is immunological hypothesis. That is, there is a hypothesis which says that there is a cell-mediated autoimmune response involving lymphocytes. It's an autoimmune response involving lymphocytes which attacks the peripheral myelin. So that is another hypothesis for the reason of Bell's palsy. Again, viral hypothesis is there. Viral infections such as herpes zoster or herpes simplex, which is the most accepted nowadays. As a reason for Bell's palsy. Now, when we come to the causes of Bell's palsy, the causes can be classified. There are many methods of classification depending on the pathway of the nerve. I'll just mention one method, that is based on the pathway of the nerve through the cranium, intracranium, intratemporal, and extracranium. So intracranial causes, that is inside the cranium, there is vascular abnormalities like stroke, etc. Then degenerative diseases of the central nervous system and tumors of intracranial cavity. Then any direct trauma to the brain, and congenital abnormalities of the brain, and agenesis, that is an failing in the development of the organ or the nerve from the embryo level. And when the nerve reaches the temporal part, that is the intratemporal causes, there's a bacterial and viral infection can be seen. It's the most common cause. Then cholesteatoma is a condition formation of a cyst in the middle ear, which can infect the ear and give an injury to the nerve. Then trauma, say blunt temporal bone trauma, longitudinal horizontal fractures of the temporal bone and gunshot wounds. Again, tumors invading the middle ear, the mastoid and the facial nerve. And iatrogenic causes, that means the causes due to medical negligence or wild treatment. The reason for an injury of the facial nerve occurs. So that is called as iatrogenic causes. So these are the intratemporal causes. And next is the extracranial causes. That is malignant tumors of the parotid gland. So once it in the anatomy you have seen that once it exits the stylomastoid foramen, it reaches to the parotid gland. So there the malignant tumors occurring in the parotid gland can compress the nerve or destroy the nerve. Again, trauma, then iatrogenic causes, medical negligence, etc., or improper treatment due to improper treatment. Then primary tumors of the facial nerve and malignant tumors of the ascending ramus of the mandible, pterygoid region and the skin. So all kind of tumors. So these tumors are considered as the extracranial causes of the uh, Bell's palsy. And the main cause of the Bell's palsy again is the latent herpes viruses, that is herpes simplex virus type 1 and herpes zoster virus, which are reactivated from the cranial nerve ganglia. Then Epstein-Barr virus, that is again of the herpes group, causing the condition called as infectious mononucleus. This Epstein-Barr virus, again herpes zoster virus is having a more aggressive biological behavior than the herpes simplex virus type 1. Other causes include diabetes, hypertension. In the last trimester of pregnancy, it is seen an increased risk for Bell's palsy, dental anesthesia, then cold exposure, otitis media infection, then head injury and sarcoidosis. So all these conditions are the other causes considered as other miscellaneous causes of Bell's palsy. So when you come to the pathophysiology of the condition, we should check the degree of nerve injury that is happening to know the severity of the disease. So how much the symptoms are manifested or the extent of manifestation of symptoms depend upon the degree of the nerve injury. So the basic levels of degree of nerve injury includes neuropraxia. It's a conduction block. Neuropraxia means there's a conduction block. It's a temporary block in the nerve due to some causes, maybe due to mild compression by a tumor or something or a growth, or from a transient anoxia due to vascular interruption. So decreased blood supply causing a conduction block. It has a complete recovery of sensation. It's temporary, and during that vascular interruption, the blood supply, the nerve loses its function, and later, very soon, it recovers its sensation. Then another condition is called as axonotmesis. So axonotmesis, here the endoneurium of the nerve, peripheral nerve is involved, but with no significant axonal disorganization. That means in the neuropraxia, the epineurium and the endoneurium of the nerve is totally all right. But here, the epineurium is involved, the endoneurium is involved. But the axonal disorganization is minimal or slight. Here the recovery is slow. It may take weeks to months and it may not be complete recovery. And the third stage is much more severe, that is the neurotmesis. In neurotmesis, there is a complete or near complete transection of the nerve. That means the nerve is almost cut off, maybe due to some injury. And there is epineural discontinuity. So epineurium, as you know, is outer covering of the nerve. It's completely discontinued. So here the neurosensory recovery is unlikely. So mostly there's less chances of regaining the sensations. So this degree of nerve injuries happen in the facial nerve, and this decides the extent of symptoms that is present and the recovery of the condition. This is a simple diagram which shows the degree of nerve injury. There's a pinched area. It can be neuropraxia, mild compression, or it can be axonotmesis, or it can be neurotmesis that occurred in that area. And depending on the degree of nerve injury, the symptoms are also seen. And the nerve signal is seen healthy. On a healthy nerve, it is seen transmitting, but the inflamed swollen nerve, it blocks the nerve signal, and afterwards we can see there is no signal to the nerve and the supplies to the muscles are destroyed. So before discussing about the exact symptoms, we'll just go through the illness history. or if we interrogate with the patient, we can ask for the history of the symptoms, just what happened just before the complete paralysis of one half of the face, or the patient may not be in a condition to speak, but the patient assistant can reply these symptoms if they are aware of it. So the most alarming symptom of Bell's palsy is the paralysis. Again, the paralysis. It's still mild in the beginning, and the affected patient think that they have a stroke or an intracranial tumor, and this is often having a sudden onset, evolves rapidly within 2 days, with the maximal facial weakness is attained within 2 days of the initial mild symptoms. And associated symptoms which might have been there, that may be due to, that may be hyperacusis may be found, that is increased sensitivity to certain frequency and volume of sound. Then lacrimation, severe lacrimation may be have occurred, and altered taste might have been occurred. So all this can be found out by the assistant. So you can ask the questions to the assistant and can find out from them. The patients may also mention otalgia, or the pain in the ear, or oral fullness of the ear, and pain in the facial area of the retroauricular, the behind the ears, and which is typically mild, and these conditions may be present just before the palsy to manifest completely. And whenever there is a neoplasm as a reason, the onset by having a slow progressive nature. And also other cranial nerve deficits may be seen if the reason for the Bell's palsy is a neoplasm or a tumor or a growth. Usually there is a slow onset, and if it is due to other infections or something like that, it is having a sudden onset, which is more common more commonly seen. And the symptoms of Bell's palsy, first is the forehead, starting from one half of the upper face to the lower face. The forehead cannot be wrinkled, and the frowning, the capacity to frown is also lost. The frontalis muscle is affected. Then the eye cannot be closed. Again, orbicularis oculi and the sphincter of palpebral fissure. On attempting closure, eyeball turn upwards and outwards. It's called as Bell's phenomenon. That is, when the person tries to close your eye, the eyeball it turns upwards and outwards. It's Bell's phenomenon. I'll explain it later. On showing teeth, the lips do not separate in the affected side. Ask the patient to show the teeth. The lips do not separate in the affected side. Ask the patient to whistle. It is not possible. The nasolabial fold, it can be seen as flattened. The angle of mouth of the affected side is seen drooping down. There is dribbling of saliva. Again, orbicularis oris, or the muscle around the lips, and the sphincter of the oral fissure is affected. Ask the patient to blow their cheeks out. You can see that the cheek puffs out with expiration. So patient can't hold the air, or they can blow because the buccinator muscle is involved. The food collects between the teeth and the paralyzed cheek again, and again the fluid runs out while drinking. Again the buccinator muscle is involved here, and the base of the tongue is seen lowered. That is stylohyoid and the digastric muscles are affected. So there is a classification of the degree of severity based on House-Brackman classification. So here the grade 1, it is normal function without weakness, is considered as grade 1. Grade 2 is there is a mild dysfunction with slight facial asymmetry and with a minor degree of synkinesis. Synkinesis is a condition called the one, if we try to move one muscle involuntarily associated, nearby muscles are also moved. There is a simultaneous movement of different muscles. That means if you try to smile, even the other muscles in the cheek or the eye nearby the eyes all get a small movement. simultaneous movement. Synkinesis. The minor degree of synkinesis is seen in grade 2. In grade 3, there is a moderate dysfunction. It's obvious but not disfiguring. Then asymmetry is present with contracture or hemifacial spasm of one side of the face, and the residual forehead motion. Motion is present uh, mildly, and there is an incomplete eye closure. That is grade 3, and grade 4, it's a moderately severe dysfunction. Again, the features are obvious, disfiguring asymmetry. Then there is a complete lack of forehead motion and an incomplete eye closure. And grade 5, severe dysfunction, asymmetry at rest and only slight facial movements are present. And grade 6, it is total paralysis or complete absence of tone or motion of one half of the face. The physical examination of the patient is important. So one of the chief features of physical examination is the Bell's phenomenon. So when we ask the patient to close your eyes, there is an upward and outward diversion of the eye on the attempted closure of the lid. That is, the eye closure is, as you know, the eye closure is incomplete in facial palsy, and the patient tries to close their eyes, which leads to just the movement of the eyeball in an upward and outward direction. It is called as a Bell's phenomenon. So it's a significant feature of the Bell's palsy. Then other common physical examination include the presence of polyps or granulations in the ear canal. So we have to examine the ear canal because it's the place inside through which the nerve passes, and as we have read it earlier, there is a cholesteatoma. That is the reason for the nerve injury or a presence of a malignant otitis externa, infection of the external ear. All these can cause nerve injuries, and if those conditions are present, there may be polyps or granulations present in the ear canal. So you have to check for that. Then we have to check for the conical bowl, that is that outside of the ear, conical bowl, the external ear. Vesicles might be present in there, and soft palate and the tongue. If it's a Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is a condition caused by varicella zoster virus. It's a herpes virus, and as I've told, it's the most common cause of Bell's palsy, or the nerve getting injured or affected. And if it is Ramsay-Hunt syndrome, there may be vesicles in the conical bowl. The examination should exclude masses in the head and neck. Then a deep lobe parotid tumor. If a parotid tumor is present, you have to check it clinically or identify it clinically by careful examination of the oropharynx and the ipsilateral tonsil, or the tonsil of the same side of the affected face. And when you examine the patient clinically, you need to ask certain questions. First of all, you have to look at the symmetry of the face, whether both sides are of equal symmetry, and check the extent of asymmetry. Then check for the nasolabial folds, where it is flattened or not, and also the wrinkles in the forehead. So you ask the patient to look upward and observe for the wrinkling in the forehead. And since the frontal belly of the occipita frontalis is affected, the wrinkles will be absent, especially in the lower motor neuron facial palsy or the Bell's palsy. But the wrinkling might be present in the central nerval facial palsy, as I have told earlier, because there is an ipsilateral connection coming from the same side of the brain. And ask for the spontaneous movements like smiling and blinking the eyes. It's not possible. And if the patient is able to smile symmetrically, but it has a flattening of the nasolabial fold, this is still a sign of mild facial weakness. Then ask to show you his teeth. The patient can't show his teeth because the platysma muscle is affected. Ask him to whistle, he'll not be able to do it because the buccinator is affected. Again, the orbicularis oculi muscle is affected. So close the eyes, ask him to close the eyes tightly and watch for the Bell's phenomenon. I've mentioned it earlier. Then assess the strength by trying to open his eyes with your fingers. Another major feature to be checked in clinical examination is the determining the sensation of taste, because it is altered in facial paralysis. The patient is asked to protrude the tongue and apply the taste solutions to the surface of the protruded tongue with a small swab. So all these tastes we have to carry along with us. So patient is asked to indicate the perception of taste before the tongue is withdrawn, as to show which taste he has felt. After each test, mouth must be rinsed. The tip of the tongue, usually sweet and the salt taste can be sensed. Sides of the tongue is sour taste and the posterior aspect of the tongue is the bitter taste. Also check the strength of the vaccinator. Ask the patient to blow the cheek against the resistance, and it is not possible if it is paralyzed. The cheek puffs out on expiration, and you have to compare the strength of forehead and the lower face. The forehead by trying to wrinkle the forehead your eyebrow against resistance, and also the muscles of the lower face. You have to compare the difference in strength.